Okay, excellent. All right, well, hi everybody who's in at the moment. We're just going to get started soon. So my name's Lucy, if you haven't already met me. I'm the project officer at the Alcohol and Drug Service at St Vincent's and also the project coordinator for DARIA. We've got a few extra faces today because Southern New South Wales LHD are joining us today for their first session of DARIA as well. So welcome to everybody from Southern. I'd just like to acknowledge the Gadigal people of the Eora Nation, who are the traditional owners of the land which I'm calling in from today. And I extend my respect to any Aboriginal people who may be on this call here today as well, and acknowledge that elders past, present, and emerging, and their strong connections to the land. So today we have Professor Hayden McRobbie as our presenter. So Hayden is a professor in public health intervention with the National Drug and Alcohol Research Centre at UNSW, and he's also the Director of Strategy Planning and Funding at the Lake District Health Ward in New Zealand. So welcome, Hayden. He's going to be presenting on e-cigarettes today as part of a Cochrane review that he was part of and sharing some insights from that. So I'll hand over to Hayden. Just a reminder to everybody, if you've got any questions that come up during the session, to put them in the Q&A function down the bottom. If you've got any tech issues, need to contact me or the admin, then just pop those in the chat, and then we will hold questions until the end of the session. All right, Hayden, I'll hand over to you. Thanks.
Sure, thanks, Lucy, and welcome everyone. I've got a few slides to get through. One of my areas of passion, as you will probably see as we go along, but I hope it's going to be helpful, and I'll make sure I save enough time for questions at the end. So let's just get straight into it. As I'll cover off soon, and as you all know, the health risks associated with tobacco use are almost entirely due to tobacco smoke or products of combustion, as opposed to nicotine. But to get the best benefits from smoking cessation, people really do need to stop smoking completely. There are health risks of smoking just a few cigarettes a day. But of course, depending on which health risk you're looking at, that varies. So if you're talking about cancer, of course, cancer risk is almost completely related to exposure over time. There are stop smoking medicines available. There are behavioural support mechanisms available to help people stop smoking, but you all know as well as I do that there are a number of people that really struggle. And non-combustible nicotine use can be seen as a harm reduction approach. And today I'm going to focus on e-cigarettes. You might see terminology with ENDS, or electronic nicotine delivery systems. I might say vaping and vape, or e-cigarette. They're all the same thing. So just shows that the vast array of different terminology that's emerged over time. There are a whole lot of different types of electronic cigarettes. There are the early versions which look very much like a cigarette, and now we're sort of down to this fourth generation or pod-like device. They all have some things in common. They all are battery operated. They essentially aerosolize a mix of propylene glycol, vegetable glycerin, usually with nicotine and usually with flavorings. In terms of nicotine, this is what, of course, keeps people smoking. It's its action on the mesolimbic dopaminergic pathway, which is rewarding the behavior. But as I said in the first slide, and to quote Professor Mike Russell, people smoke for the nicotine but die from the tar. Now, I just want to spend a little bit of time on nicotine delivery. And first up, nicotine delivery from your standard combustible cigarette. And this is showing both venous and arterial blood concentrations here in nanograms per mil. And you can see the very quick spike you get in arterial blood nicotine level after just a few puffs. So very large or rapid delivery of nicotine to the brain quite quickly. In terms of nicotine delivery from nicotine products, and these are all venous plasma nicotine concentrations, this time in micrograms per litre, but same thing. You can see here, if I demonstrate with the cursor, this is delivery of nicotine from a standard combustible cigarette, here peaking just over 25, but in general, it's somewhere around 20 nanograms per mil. This line here is your 4 milligram gum if you use it properly. But just to point out and summarize that most of these nicotine replacement therapies don't peak until around half an hour after use, and the nicotine patch is certainly much slower. There are two types of patches, the 16 and 24 hours, but most of them reaching their peak within sort of 6 hours of starting to use them. Now, what does nicotine delivery from electronic cigarettes or vaping products look like? These data are getting a little bit old now, but some work that I was involved in with Peter Hayek in London. And this is looking at nicotine delivery from a standard combustible cigarette here in the light blue line versus nicotine delivery from a range of electronic cigarette products. So bearing in mind, these data are from 2016. The technology's moved on a lot in the past 6 years, but I guess you can all appreciate here that the nicotine delivery looks much more like a combustible cigarette as opposed to what I showed you with nicotine replacement therapy, i.e. it's peaking within the sort of 10 minutes after use. But technology has got better, and here are some data looking at this particular pod device. This is Juul. This is a high nicotine delivery system, 59 milligrams per mil. And this is blood nicotine, again, venous blood nicotine over time. The dotted line is from Juul, the solid line from a cigarette. So pretty much the same as a cigarette smoke. So e-cigarettes can deliver nicotine quickly. This is great, of course, for helping people stop smoking, but the downside is if you've got this in the hands of never smokers, then the abuse liability potential is certainly greater. Now, I just want to make just pause here. The amount of nicotine that's delivered to the blood is not just dependent on the amount of nicotine or the concentration of nicotine in the device itself. The puffing behavior, very much like cigarettes, the puffing behavior of electronic cigarettes can differ or can give rise to different levels of nicotine in the vapor and therefore in the blood. Now, the data you're seeing here is nicotine in the vapor or the aerosol itself, but essentially what it's showing, and quite strongly in the Views product here, the dark gray bar, that as you increase puff volume and puff duration, then you get more nicotine in the vapor itself. So this is just like smoking cigarettes. People compensate. They can puff on their cigarette smoke differently. They can vape differently, and that can also affect blood nicotine delivery. So key point here is it's not just all dependent upon the amount of nicotine in the device itself. Okay, want to move on now for the evidence regarding electronic cigarettes for assisting smoking cessation. And I'm going to draw upon the data from the Cochrane systematic review, of which I'm a co-author. So these data are from last year. So in this most recent review, we included evidence up until May 2021. There'll be some more for us to look at when we get around to the next version. The main focus for evidence is randomized controlled trials because they often give you the most reliable evidence. But we did include some cohort studies in this Cochrane review as well. The data I'll be presenting in the forest plots, though, are from randomized controlled trials. The included studies had to report on smoking outcomes for at least 6 months. And we also looked at unwanted effects or side effects in people that use vaping products for at least a week. Overall, we found 61 studies, just nearly 17,000 participants. And we also found studies that compared electronic cigarettes with nicotine replacement therapy, varenicline, nicotine-free e-cigarettes, behavioural support, and no support. This is a living review now, so we've been running searches regularly since December 2020, and then updating the review as we've gone along. Okay, so we cut to the headline results. Electronic cigarettes for smoking cessation are no magic cure. You probably knew that already, but I know people often perhaps overhype them as something that's the remarkable cure. It's not, but what we concluded was that more people probably stopped smoking for at least 6 months using nicotine-containing e-cigarettes than nicotine replacement therapy or nicotine-free e-cigarettes. And those were the studies and the participants there on the left. But in absolute terms, if you took 100 people that used nicotine-containing electronic cigarettes, somewhere between 9 and 14 of them will quit long-term, that is for at least 6 months. Non-nicotine e-cigarettes, around 7 will quit for at least 6 months, and NRT, around 6 will quit for at least 6 months. Behavioural support or nothing, around 4 people quit smoking for at least 6 months. So that's kind of in line with what we know. But as you can see, most people are still relapsing to smoking. We're just looking at the forest plots, and you can see where the larger studies were. And these were studies that compared nicotine-containing e-cigarettes with nicotine replacement therapy. I've put the absolute quit rates down here. So here you can see at least 6-month follow-up, roughly 18% had quit smoking if they were using nicotine-containing e-cigarettes versus 10% on NRT. The study by Peter Hayek and colleagues, this was 1-year follow-up. This study has most of the weight in this meta-analysis, and this was a study where they used e-cigarettes in combination with face-to-face behavioural support. So they had their standard NHS 6 sessions with 4-week follow-up, and these were the quit rates at 1 year. So you can see there the quit rates among the e-cigarette group were almost double that of the NRT group. In terms of nicotine-containing e-cigarettes versus non-nicotine-containing e-cigarettes, here are the data. So nicotine-containing e-cigarettes are significantly more effective than non-nicotine-containing e-cigarettes. Some people would argue that this is non-nicotine e-cigarettes would be the appropriate control. But remember, you've still got some puffing behavior and some behavioral replacement with non-nicotine e-cigarettes. So this is where you get some benefit out of these. In terms of nicotine e-cigarettes versus behavioural support or no support, again, still effective, but you can see here the quit rates are really low. This is quite highly influenced by the Halpern study, which essentially gave e-cigarettes to people that weren't necessarily, or offered e-cigarettes to those not necessarily interested in quitting. But there you go, that's overall what we're looking at there. And then another couple of studies have done a bit of a hybrid pattern here where they've used both arms got nicotine replacement therapy, and then they either got a nicotine-containing e-cigarette versus a non-nicotine e-cigarette. The use of the combination with nicotine-containing e-cigarettes just scraped in terms of significance, but you can see the overall long-term quit rates are still relatively low here. And these studies provided very limited behavioural support as well. Currently, only one study comparing nicotine-containing e-cigarettes versus varenicline. Varenicline's still our best or most efficacious smoking cessation therapy. Here, the results favoured varenicline, but quite a small study. So 48% quit smoking for at least 6 months in the varenicline arm versus 14.8% in the e-cigarette arm. So these are something we saw. These data need to be strengthened with some decent size randomized controlled trials. That's what you're looking at overall with the different comparisons, but overall nicotine replacement therapy, nicotine containing e-cigarettes are certainly more helpful than non-nicotine containing e-cigarettes and NRT at helping people stop smoking. Now, what about adverse effects? At least in these trials, there were low numbers of adverse effects across all study groups. So we don't have a lot of certainty in this regard to adverse events. The most common side effects associated with e-cigarette use are your local mouth and throat irritation. Some people report headache, cough, and nausea is also commonly reported, although these are mostly time limited and people get used to these over time. In all of the studies, there were no significant differences in the rates of serious adverse events. Now, I want to just put a caution in here, of course, that it's difficult to really power studies for detecting adverse events because they're so low, they just don't occur. And of course, a lot of people, when they stop smoking, even switching to a less harmful product, report benefits and health outcomes. So nothing is as bad as smoking. And whilst there's general agreement that e-cigarettes are less harmful than smoking, I don't think they're going to be completely without harm. So here you go, summary of the findings from the Cochrane review. E-cigarettes probably do help people stop smoking for at least 6 months. They probably work better than nicotine replacement therapy and nicotine-free e-cigarettes. They may work better than no support or behavioral support alone, but we need some more data to strengthen that conclusion. And they may not be associated with serious unwanted side effects for at least the period that are used in these trials. So I just want to touch on the last few slides around toxicant exposure. Whilst we don't know the long-term health consequences associated with long-term vaping, we do have some data to help us think about what might be going on here. Now, in this particular study, they randomized 264 smokers who didn't want to quit, and they went into one of 4 groups. The first one, they could use a nicotine-containing e-cigarette ad libitum. In this group, complete substitution with electronic cigarette, they were instructed to stop smoking and switch to using e-cigarettes. This one, they were instructed to stop smoking and use nicotine replacement therapy, and this was gum or lozenge. And then the 4th group was kind of your control group where they just kept on smoking their own brand of cigarettes. Now, here down the side, I've got, I just selected a number of measures in the study. There were many more, but just number of cigarettes smoked per day, the total nicotine equivalents, the NNAL, a tobacco-specific nitrosamine, acrolein, and this one's a biomarker for propylene oxide. So compared to baseline, so this is looking at compared to baseline when they were all smoking, you can see a significant reduction, of course, in cigarettes per day in those that were asked to completely switch using electronic cigarettes and nicotine replacement therapy. What you notice here is that electronic cigarettes were slightly better than nicotine replacement therapy at substituting nicotine. Okay, so this had a less of a reduction from baseline than they did with the NRT. And that relates back to my earlier slides around nicotine delivery. In terms of toxicant exposure, there was a significant decrease in toxicant exposure in these groups from baseline, but also in those that were using e-cigarettes ad lib. But I hope what you can notice here is that actually there was very little difference between the substitution with e-cigarettes versus substitution with nicotine replacement therapy. So at least in some of these measures, e-cigarettes weren't exposing people to a whole lot more toxicants than nicotine replacement therapy. Now, just looking at emissions, and this is just looking at toxicant exposure in vapor here. And the study actually compared Juul, which is that little pod device that I showed you earlier on, with a standard combustible cigarette. And you can see that, look, compared to smoking, at least in some of these measures, they're many-fold less. Not completely zero, though, of course. And in terms of particulate matter, there wasn't a whole lot of difference there. I've just also included some data here from other e-cigarettes. These weren't part of this study, they were taken from elsewhere, but I'm just showing you here for comparison that not all e-cigarettes are the same. And I just wanted to note this because I think e-cigarette technology, as it's improving, there is a way to reduce it, not completely take it away, but we should be able to reduce the toxicant exposure further. So we've got better devices, not superheating the products, not superheating the liquid, will certainly reduce the risk of toxicant exposure overall. And just here, looking at urinary biomarkers. So this is biomarkers in urine by participants that use different devices. So this is just a cohort study here, but this is looking at those using a cigar-like device, a fixed power electronic cigarette, a variable power electronic cigarette, and a pod device. Now, overall, you can see here that the pod device, at least in one of the measures, it looks like it may potentially be less harmful. I use those words very carefully than some of the other devices, but just caution here because it's a small study and we don't know this for sure, but I think it gives an indication that we may be able to get devices that could be a little bit better and potentially less harmful than others. Now, nicotine concentration and toxicant exposure. I'm going to mention this because a way that a lot of people try to get off their vaping product is to use a lower nicotine concentration. Now, in this particular study, we looked at, we took real people and we looked at their puffing behaviors when we switched them from a high nicotine e-cigarette to a low nicotine e-cigarette. And then we replicated those puffing behaviors in the lab to measure these toxicants, formaldehyde, acetone, acrolein, in the vapor based on those puffing patterns. And what you can see here is that when vapors reduce their nicotine concentration, they increase the duration of their puff, and with that, potentially increase the exposure to these toxicants. So I've been saying to people, especially when they're switching from smoking to vaping as the first part, don't go too low on your nicotine. In doing so, you might compensate and actually end up with higher levels of exposure of these toxicants than if you had used a higher nicotine solution. It's not the nicotine, at least for people who smoke and switching, it's not the nicotine, of course, that's the cause of any problems. It's the other factors in the vapor, for example, the propylene glycol, vegetable glycerin, and heating those, as well as perhaps some of the flavorants that are present in e-cigarette liquid. So just to finish off then, how do you go about helping people stop smoking? Well, this is how I do it. I explain what I can offer. And as a medical practitioner, I've got a few things that I can offer, but they're limited to a range of stop smoking medicines and behavioral support. And where I can refer to a local stop smoking service or quit line, that's what I recommend the best chance of quitting. But I also see now many more people that say, yeah, I've tried that and I've tried this and I called Quitline and I did all of these things and they just didn't work. And what about e-cigarettes? Are those going to be a good thing for me to switch to? And so you just say, well, look, can I tell you what I know about electronic cigarettes? And this is what I tell them, that, yep, electronic cigarettes can help people quit smoking, but there's certainly no magic cure. And whilst we know that they are less harmful than smoking tobacco, we still don't know the risks associated with long-term e-cigarette use, only that they're likely to be many times less harmful than smoking. And I also make the point of saying, you know, e-cigarettes are for people who smoke. You know, these should not be used by non-smokers. So just keep that in mind. When we're trying to get people to switch, they've got to give these things a really good go. It's funnily the same sort of story as getting people to use nicotine gum correctly. You have to use enough of it. One bit of gum every now and then, you're probably not going to switch to gum very quickly and therefore, you know, stop smoking. So same for e-cigarettes. Really need to be using on a regular basis to enable them to make the switch. You also need to try some different devices. If the first one doesn't work, you might need to try something a little bit different. And models that deliver nicotine better are probably going to be those that are more effective in helping people to stop smoking. It can take some practice how to learn the device. People often comment on the harshness of vaping products, especially if they're using one with a slightly higher nicotine concentration. It's really common. And you might as well mention it because it's going to be there and it can sometimes put people off. Reading the manufacturer's recommendations and instructions, these are electrical devices, so even the simple message of making sure that you use the charger that comes with the devices is going to be useful. And probably one of the most important things is to aim to stop using combustible cigarettes as soon as possible. So making that switch from smoking to vaping completely. And then I add on one more point, which is as soon as you feel comfortable that you're not going to go back to smoking a cigarette, aim to stop smoking as well. Now, that can take a few weeks. For others, it probably takes a few months to perhaps even years. We see long-term users of nicotine replacement therapy. So we acknowledge that not everyone's the same and some people will make faster progress than others. In terms of health risks, I think this particular report from the National Academy of Sciences, Engineering and Medicine summarised that, look, overall, e-cigarettes are less harmful than smoking, but they're not without biological effects in humans. So they're not completely risk-free. So if you're a smoker who's switching completely to vaping and quitting smoking, then you're going to see a reduction in health risk. I haven't put any numbers on here because I don't think we know exactly what that proportion of risk reduction is. And likewise, if you're a never smoker who becomes a regular vapor, then it's likely that there's going to be some increase in health risk. But again, we don't know exactly what that health risk is. These products just haven't been around for long enough. But we are starting to see a number of young never smokers in particular that have taken up vaping and have become regular vapors. So in conclusion, not a magic cure, but e-cigarettes can help people stop smoking. There will be more data that will add to the Cochrane review over time, and that will help strengthen that evidence. There are likely to be some adverse health consequences associated with long-term vaping. And so I think the concern that some people have is warranted. However, we've got to keep that in balance for the concerns of the health and well-being of people who continue to smoke. There's still nothing as harmful as smoking. And for those that have tried everything else, and that's certainly a recommendation of the Australian guidelines, general practice guidelines, that see this as a second tier approach for smoking cessation. And for smokers switching to vaping and stopping smoking completely is the most important thing here to get the reduction in health risks. The current literature we have at the moment supports that statement that they are less harmful, but not harmless. And I think to mitigate any concerns, as I said, over the long-term consequences, advise your ex-smokers who have become regular vapers to stop vaping as soon as they feel able that they're not going to relapse to smoking. And I think that, yes, indeed, is my last slide.
Thank you very much, Hayden. I'm going to hand over now to our clinical lead, Chris Tremonti, to manage the question and answers. So everyone, there's just a Q&A box down the bottom that you can put questions into. Otherwise, if you use the raise hand function, I can unmute you as you come up and you can ask a question using your audio as well.
Thank you, Lucy. And may I say thank you very much, Professor McRobbie. That was an excellent talk, I think, not just for the data that you presented and obviously the work you've done with the Cochrane review, but I think you've really nicely addressed a lot of the issues that the people have with vaping and the reservations that are out there in the community. And you probably saw there was a recent MJA article that was actually featuring somebody that I work with in another research project that was sort of this highlighting this notion of vaping being a gateway. And certainly there are those concerns out there. Of course, we don't know entirely about all the the potential long-term effects, and there is some exposure to chemicals and what that can occur and so forth. So I really appreciate that. As I have the floor, I might start with the first question, and I wish I could find the article. And sorry, the other thing I think that you covered brilliantly was this concept of different nicotine levels. My background is that I'm also a clinical pharmacologist, and there's and a lot of the pharmacologists that I've worked with certainly feel that the strengths they put on cigarettes are about as meaningless as everything as the advertising that comes with cigarettes and so forth. And I can see you nodding there as well, so I'm glad you kind of agree with that. Just on that, then I guess my question is about just dosing. I was desperately trying to find the study that I could that I remember quoting this from, that there was a study that smoking around 18 cigarettes a day was the equivalent of about 40 milligrams of nicotine liquid that was vaped. I can't remember what study that was, and I apologize, I don't have it in front of me. Do you think that is a reasonable ratio for putting people on for dosing purposes and so forth if they want to go straight to e-cigarettes?
I think it's reasonable, and I know the TGA have got some guidance on their website too for helping prescribers, work out what's needed. I guess the caution, well, not really caution, but noting that people will get the nicotine that they're used to getting regardless. They'll be titrating pretty much to what they would have got from smoking. So if they're on a too lower strength of nicotine in their e-liquid, they'll churn through a lot of liquid to get that. If they are too high, they'll use less, but they'll often complain of the side effects of that. So I think it's trying to find that middle ground. If they're on a pod device, most of the pod devices are fairly standard, around 40 milligrams per mil, or around about that space. If you're on some of the tank systems, then I would often get people to start somewhere between 12 and 18 milligrams per mil of nicotine concentration in their liquid, and go from there.
Sorry, can you just repeat that again? Sorry, so just roughly, sorry, what was the equivalent you gave there?
So usually if I was seeing a sort of 18 a day a smoker, then I would start them, if it was a tank system and they were using liquid in a tank-based system, then I would start somewhere between 12 and 18 milligrams.
Oh, okay, so quite a bit less than what.
But if they're using a pod type device, then you'd start around 40. because it all depends too on the power of the device and how efficient people are at getting how efficient the device is of getting the nicotine from the liquid into the vapor.
Yeah, no, absolutely. Thank you very much. That's very helpful and useful information, because I'm sure there are other clinicians out there who sort of don't know where to kind of start with that sort of thing.
But the TGA does have some really good guidance. Nothing's perfect in this space, and it's a little bit the same with nicotine replacement therapy. My advice for that is use as much as it takes to get you off the smokes.
I don't remember ever giving anyone a 14 milligram patch. I don't tend to waste my time with it. So
absolutely. And really the early studies of 4 milligram gum, they were really using a good 12 to 15 pieces a day with a particular technique to get the nicotine out of it. So yeah.
I could ask questions all day, but I'll let some other people have a turn. We've got a question here about advice regarding school-age students and vaping. There's a lot of requests for advice around this issue, coming from high schools and so forth. And if you have any advice around school-age students and vaping.
Yeah, we've seen this here in New Zealand as well, and our survey data are showing an increase in youth vaping rates, and we're getting certainly more questions from schools about what to do about this. There's no hard and fast rule to all of this, but having some good school policies around vaping, or not vaping as the case may be, or the case is a good start, and enforcing those policies, but not enforcing it in a way where you're suspending kids from school for having vaping products. That's not a particularly great way of engaging with young people. The evidence, mostly from the US, suggests that we should be having these frank conversations with our young people, exploring the issues of why they shouldn't be vaping, being careful that we're not trying to pull wool over eyes and make claims that are completely crazy, because they'll see right through that. In terms of helping people who are vaping quit vaping, the evidence is a little bit thin on the ground at the moment. There are some data to show that text-based messaging programs might be particularly helpful for young people to quit vaping. Others are trying pharmacotherapy in this space, although the evidence is scant, to say the least. So that wouldn't be my first port of call to prescribe nicotine replacement therapy for young people who vape, but to utilize some of the behavioral techniques that we have for helping people stop smoking can probably be translated to helping people stop vaping.
I hope that helped answer the question. If I might follow up on that, we've touched on twice now the concept of children being vaping and being a gateway. I had seen that there was some evidence that perhaps those who vape were people who probably would have smoked anyway. I don't know what you thought about that, some of that evidence.
Yeah, I think most of the evidence from studies show that young people who vape are likely to go on to smoke. Obviously, I'm talking about young people who have never smoked who vape that go on to smoke versus young people that don't vape. But yes, you're right, Chris. This is often said that those young people would have gone on to smoke anyway. It's not the easiest thing to tease apart, though, because it relies on you collecting measurements for a whole host of different things in terms of behavioral factors and genetic factors and a host of different things, as you all know, to try and predict what this might go on. But I don't think you can ever rule it out, that vaping isn't an absolute not a gateway to smoking. I think it probably is, but the risk is probably relatively small.
Look, and thank you for that. And look, I might follow on with this next question, which is about sort of medico-legal issues with advising people to vape, seeing as we don't know, I guess, some of the long-term issues. There is some evidence that it's less harmful, makes sense, but if it's not harmless, is there, I guess, medical legal exposure from recommending it?
Yeah, I agree. And that's why I personally take the approach of saying what I can offer. And I'm offering the things that I actually can offer as a medical practitioner. However, I take the opinion that if people are asking about these products, then I need to give not a long discussion about it, but at least a very short discussion about what I know. And in that discussion, we talk about risks versus benefits, and in order to enable people to make an informed decision about whether they want to vape or not. And I can't provide people with vaping products. And I'd be careful of saying, I absolutely recommend that you go and get a vaping product to switch. And look, the chances are that you're more likely to get a comeback that's, I tried this, it was useless, and I'm back smoking again. So I think that's a little bit of a fine line, Tony, when you're looking at those things. But if you can take it from a viewpoint of, well, let me tell you about what I know, and I'm not telling you they're not completely harmless, but I do know that for some people that they do help them stop smoking.
Thank you for that. I might pivot slightly then. There was a question as well about price point and access and the differences in other countries. I'm just wondering if you can comment on that to some degree.
In general, electronic cigarettes are significantly cheaper than smoking. And I still think Australia's got one of the highest cigarette prices in the world. New Zealand's getting fairly close behind now. And in general, vaping would be probably less than a third of the cost of smoking, depending on how much you're getting through. So there is a price point difference that's quite notable.
And in terms of access, I mean, I have hard enough time getting my head around the Australian legislation. Is it similar in?
There's so many different approaches around the world. So, Australia, you've got prescription only. New Zealand, you've got relatively free access for 18-year-old, over 18 and older, but with limitations of what you can buy where. So in supermarkets and gas stations, for example, you're restricted to only 3 flavors: tobacco, menthol, and mint flavor, e-cigarettes. If you want anything else, you have to go to an R18 specialist vape shop, although you can buy online. The UK are probably more similar to New Zealand, but don't have some of the other purchasing restrictions, but they'd have other restrictions such as a limit on the nicotine concentration and a cap of 20 milligrams per mil, which is as per the EU Tobacco Products Directive. It's interesting, actually, the UK, Europe, we haven't seen the big uptake in youth vaping that we've seen in the US and to a lesser degree in New Zealand. And I do wonder whether that's because of the early regulations that were put in place. And we're talking back in 2014 here. So whether those early restrictions around advertising, early restrictions around access might have actually played a role in limiting uptake in young people. It'll be interesting to see what happens with the Australian experiment. If people can still get vaping products and they stop smoking, and you're also seeing no real rise in vaping among non-smokers, well, then maybe that's great.
Yeah, look, it's only from my own personal experience. I've worked in addiction medicine for a number of years. I've not written many myself, which makes me assume that most people still have an access, and there hasn't been a crackdown, as it were, on the supply at this point in time.
I guess too, we want to keep a lookout for perhaps unintended consequences of the legislation in terms of people being fined, as you've got people who are dependent on nicotine. They're trying to do something about it. They're importing without a prescription, or they're importing more than their allowable 3-month supply, being whacked with a fine in what is likely to be a population that is most likely from lower socioeconomic groups. Doesn't exactly help matters overall. So that might be something to keep an eye on too.
I note that there was a comment from one of the registrars here. That just mentioned, very anecdotal, have a few friends who used to smoke socially, started vaping as they thought it was healthier, and now have proper addiction. Nicotine addiction is much easier and cheaper to vape. So just following up on that comment, that perhaps that is an issue. Thank you for that. The next comment, which is very practical, and I'm thrilled someone's asked it. If we do a substance use assessment, how do we quantify and equate as well? So, what have you any advice for, particularly, I guess, the junior doctors around that?
It's again a little bit difficult, and if you're talking about people who smoke that are switched to vaping, I'd kind of base it on what they were smoking before, bearing in mind that most smokers, when they switch, will try and maintain as close to the nicotine content as they did. I think, given this is relatively new, we should be recording vaping use, especially if it has nicotine in it, and quantifying. An easy way to ask, what's the concentration of nicotine, and how, ask about the size of the container of liquid, if they're using a container of liquid, or number of pods, and ask how long that lasts for. I think those are probably the best way that we have to sort of quantify exactly what people are getting and using. And the same probably applies for those that have never smoked, that are now vaping, that you can record those data. There's so much that you could record. The type of device, the number of pods you might be using, it opens it up to a kind of a big research project, I suppose. And especially over time, if you were looking at potential health harms, you'd probably want to be looking back at the medical record at some point to see when they started, how much they were using, what type of device, because all of those things matter.
Yeah, absolutely. And I must say, the only thing I'll say that from my own experience, patients often don't have a clue what the concentration is. Yeah. They often tell you how long it takes them to get through, and they can give you a rough guide on how many mils it is or whatever else, but they often are absolutely in the dark on what the concentrations are. So yeah, and I guess perhaps there's it might be tricky because the products are unregulated, and that it's hard to know. Pivoting slightly, there was a question about just sort of mentioning that varenicline still has strongest evidence and is still very underutilized. Obviously, there's the issue of supply at the moment, though, as I understand it, they have been able to get some Canadian stock or something that they've managed to get. So for those of you who weren't aware about that, did you have any experience of vapes as a gateway to intervention for smoking cessation or reduction? So perhaps going the other way, so where they haven't tried varenicline, you've had patients perhaps come to you and say, or a clinician and say, I'd like to try vaping, and they say, well, have you tried this before? No, not really, or anything like that.
Yeah, you're absolutely right, Nadine. We haven't utilised varenicline to its potential, I suppose. And you know as well as I do the background to some of that with the early concerns with psychiatric adverse events. And I think that really took a bit of a step backwards, especially for those with addictions and mental illness. And it wasn't until the Eagle study that we sort of saw that there was really no increase in the rate of these serious psychiatric adverse events in varenicline compared to nicotine patches, bupropion versus placebo. So I think that was a pity, but I think some of those concerns still exist. I guess it is a bit of a gateway to intervention. If you can sell it as, if I'm getting the question right, that you'd be saying, hey, have you tried varenicline? Interestingly, people are looking at cytosine and varenicline for vaping cessation. I think those might be quite useful tools for that purpose. But the studies that are ongoing at the moment are quite small. So we'll need bigger trials to confirm that.
And look, again, people are probably sick of the sound of my voice, but if I can add, I mean, the number of times you'll ask a patient about their experiences with varenicline, they took it for a couple of days, they didn't actually set a quit date, which is what how you're supposed to do it. There's often anxiety around nightmares, but I think empowering people with the knowledge around that is important as well. So sort of saying you will probably get, you will probably have vivid dreams. That will happen. But if you're aware of it, then it's not going to hurt you.
I think, and you know this with the drug and alcohol field, that we often, well, in mainstream, we often don't give enough information around some of these medicines. We just hand it out with very little instruction at all. And I agree. And when you work in the space, you say, right, you're probably going to feel sick, and you're probably not going to sleep very well, or you might have really weird dreams. Expect it. And if they don't get it, great. If they do, at least they're forewarned. But this, this applies to vaping as well as nicotine replacement therapy. If you're going to get people to use it, they need to stick with it. They need to know about the possible adverse effects, no matter how minor they might be. And also know that it takes a little bit of work. There's nothing. And as you see with the electronic cigarette data, these are no magic cures either. We still haven't found the perfect thing to beat combustible tobacco.
Absolutely. At the moment, I can't see any more questions. I'll give people an opportunity to ask more. I will just one thing I was going to also mention. Just have you had any difficulties with patients that have struggled to access vapes at all, like they've never done it before and they've seen you for the first time, and you've given them a script
well, I'm lucky because most of my clinical practice is in New Zealand, so I don't have any.
Oh, of course, I'm sorry. I thought you had
vaping products, so I'm lucky in that regard. But I know when we're doing some work with the TGA, some of the questions from colleagues, they had a lot of questions about getting prescriptions and a slight unease about prescribing something. And I guess that's, going back to Tony's comments, that's kind of the thing that you've got there. And as soon as you have a prescription, you're recommending or endorsing this as a tool. But I think in terms of, just trying to give people that advice on the risks and documenting those. I mean, like we do with other things, discuss with patient potential risks, especially associated with long-term use.
I completely agree. Time is often a better tool than a pen when it comes to your interactions with a patient, and particularly, in medico-legal issues as well. If you can give people time, most people don't like to sue doctors that are nice to them, in my experience, anyway. Well, I don't know if we've got any other questions. And it's 3:27. We might call it there. But again, Professor McRobbie, thank you very much for your time, your expertise. It's a hot button issue. I'm glad this didn't come to blows, because I understand sometimes the conversations around vaping, people have some very strong opinions one way or the other. So I'm glad we've got somebody that's got a rational sort of viewpoint on it all, and can give us the evidence and can see both the pros and the cons of the treatment that's out there.
Great. Hope that was helpful.
No, thank you very much. It was brilliant.
Bye-bye.
Thanks again, Hayden. We will sign off there and we'll see everybody next week at Daria again at 2:30 till 3:30. And there'll be some comms going out around the topic of presenters for next week as well. So thanks, everybody.